Musculoskeletal Radiology. Metabolic bone diseases. Hyperparathyroidism. Primary hyperparathyroidism. Introduction. Primary hyperparathyroidism, a condition caused by excessive secretion of parathyroid hormone, PTH. This leads to a range of skeletal and metabolic changes. Let's dive into its radiological and clinical features. Radiological features. Imaging plays a key role in diagnosing primary hyperparathyroidism. The main radiological findings include 1. Subperiosteal resorption. This is a hallmark feature of primary hyperparathyroidism. It's most prominent along the radial aspect of the second and third proximal or mid-phalanges. This finding is highly suggestive of the disease. 2. Salt and pepper skull appearance. This describes a granular demineralization pattern in the skull, giving it a distinctive mottled appearance. It's an important indicator of chronic bone turnover. 3. Brown tumors or osteitis cystica fibrosa. These are multifocal irregular lytic lesions, typically seen in the metaphyseal regions of long bones. They represent areas of bone loss due to excessive osteoclastic activity. Clinical features. Primary hyperparathyroidism is often associated with hypercalcemia, which may manifest as fatigue and weakness, bone pain and fractures, renal stones due to increased calcium excretion, abdominal symptoms such as constipation or nausea. X-ray of the skull showing salt and pepper appearance with multiple punched-out lesions, classical of primary hyperparathyroidism. Brown tumors of the hands in a patient with hyperparathyroidism. Subperiosteal bone resorption in a patient with primary hyperparathyroidism. Secondary hyperparathyroidism. Introduction. Secondary hyperparathyroidism, a condition that arises due to a compensatory increase in parathyroid hormone levels, most often as a result of chronic health conditions. Etiology. The most common cause of secondary hyperparathyroidism is chronic kidney disease, CKD. CKD leads to hypocalcemia, due to reduced calcium absorption and impaired vitamin D metabolism. This triggers a compensatory increase in PTH secretion, which attempts to restore calcium levels but causes skeletal changes in the process. Radiological features. The skeletal findings in secondary hyperparathyroidism are distinct. Let's go through them. 1. Rugged Jersey spine. This classic radiological sign refers to alternating bands of sclerosis and osteopenia in the vertebral bodies, resembling the stripes of a rugby jersey. It highlights the abnormal bone remodeling caused by PTH. 2. Chondrocalcinosis. Another key finding is calcification of the meniscus, commonly seen in the knee and wrist. This reflects calcium phosphate imbalances associated with chronic kidney disease. 3. Increased bone sclerosis. A hallmark feature of secondary hyperparathyroidism is diffuse bone sclerosis, reflecting the excessive bone turnover and abnormal bone density patterns. The origins of this radiological sign are clearly illustrated. The bands or hoops of a traditional rugby shirt replicated in the bony changes of the spine. Rickets. Introduction. Rickets, a condition that primarily affects children and is caused by a deficiency in vitamin D. This deficiency impacts bone development and can have significant clinical and radiological manifestations. Etiology. Rickets is a result of vitamin D deficiency in children, which leads to defective mineralization of the growth plates and bones. Clinical features. Clinically, children with rickets often present with widening of joints, most noticeably in the wrist and ankle. Another characteristic feature is the bowing of long bones, particularly in the legs, due to soft and weakened bones under the stress of weight bearing. Radiological features. Radiological imaging plays a crucial role in diagnosing rickets. The earliest sign is an increased growth plate, or zone of provisional calcification. As the disease progresses, the metaphyseal ends of the bones show characteristic changes, such as cupping, splaying, and fraying, where the edges of the metaphysis become irregular and widen. When the healing begins, you might see a white metaphyseal line, which indicates new bone formation. Differential diagnosis for white metaphyseal line. Now, the white metaphyseal line is not specific to rickets. It can also be seen in other conditions, such as 1. Healing rickets itself. 2. Lead poisoning, where lead deposits in the growth plate. 3. Treated leukemia, due to therapy-induced changes. 4. Scurvy, a condition caused by vitamin C deficiency. Anteroposterior radiograph of the wrist and hand in a child with rickets. A. Rickets. Anteroposterior radiograph of the wrist and hand in a 3-year-old child with nutritional rickets. The child had been put on a strict diet without dairy products. Note the widening, cupping, and fraying of the distal radius, arrowhead, and ulna metaphyses, with an associated increase in the thickness of the growth plate, arrow. These changes are the consequence of disordered endochondral growth. B. Normal. Radiograph of the hand of a healthy 3-year-old child without rickets. Vitamin D deficiency rickets in a child. Characteristic radiographic findings of rickets include widened metaphyses of long bones and frayed metaphyseal edges, consistent with poor mineralization of the growth plate, as well as bowed lower extremities. Anteroposterior and lateral radiographs of the wrist of an 8-year-old boy with rickets demonstrates cupping and fraying of the metaphyseal region. Scurvy. Etiology. Scurvy results from a deficiency of vitamin C, which is essential for collagen synthesis. A lack of collagen weakens blood vessels, bones, and connective tissues, leading to its characteristic features. Clinical features. Clinically, scurvy often presents with bone pain, primarily due to subperiosteal hemorrhage, where bleeding occurs beneath the periosteum. Severe pain can cause pseudoparalysis, making children reluctant to move the affected limb. Radiological features. Radiological findings are key to diagnosing scurvy, and there are several characteristic signs to remember. 1. Frankel's white line. This is a dense, well-defined line of provisional calcification at the metaphysis. 2. Wimberger sign. Sharp, well-defined margins of the epiphysis caused by cartilage destruction. 3. Pelkin spur. These are bony projections seen at the metaphysis resulting from disorganized bone formation. 4. Trummerfeld zone. This is a loosened area just above Frankel's white line caused by reduced bone density. 5. Lastly, subperiosteal hemorrhage appears as periosteal elevation on imaging, reflecting bleeding under the periosteum. Chronic osteomyelitis. Introduction. Chronic osteomyelitis, a long-standing bone infection characterized by unique pathological and clinical features. Pathological features. Chronic osteomyelitis has 3 hallmark pathological features. 1. Sequestrum. This refers to a piece of dead bone that appears dense and sclerotic. It's often trapped within the infected area and is a key feature of chronic infection. 2. Involucrum. This is the granulation tissue that forms around the sequestrum. It appears translucent on imaging and represents the body's attempt to heal the infection. 3. Cloaca. A cloaca is an opening in the involucrum that allows pus to drain, often forming a sinus tract to the skin. This is a critical feature for identifying chronic osteomyelitis. Clinical note. Clinically, patients with chronic osteomyelitis present with recurrent infection, often involving periods of remission and exacerbation, localized swelling at the site of infection, discharge from a sinus tract, which can be persistent and foul-smelling, Child with chronic osteomyelitis. 4-year-old boy with chronic osteomyelitis. Radiographs of the femur demonstrate pathologic fracture and involucrum. Arrow. Adult with chronic osteomyelitis. 39-year-old man with chronic osteomyelitis of the tibia and a draining wound. Plain films, A and B, demonstrate a sclerotic sequestrum in the defect of the tibia. Arrow. MRI, axial T1 and T2 images, C and D, show the sequestrum, arrow, in the intraosseous abscess. The abscess, sinus tract, can be seen extending to the skin on the T2 image. Arrowhead. Osteoporosis. Clinical features. Osteoporosis is marked by a generalized decrease in bone density, which weakens the bone and makes them prone to fragility fractures. These fractures can occur with minimal trauma, commonly affecting the hip, spine, and wrist. Radiological features. On imaging, a classic sign of osteoporosis is the codfish appearance of vertebra. This refers to the flattened vertebral end plates caused by weight-bearing stress on weakened bones. However, remember that the codfish appearance can also be seen in the osteomalacia, a condition caused by vitamin D deficiency in adults. Investigation of choice. The gold standard for diagnosing osteoporosis is a DEXA scan, or dual energy X-ray absorptiometry. This scan provides a precise measurement of bone mineral density. Scoring system. The DEXA scan results are interpreted using the following scores. T-score. A score between -1 and -2.5 indicates osteopenia, a precursor to osteoporosis. A score of less than -2.5 confirms osteoporosis. Z-score. This compares the patient's bone density with age-matched controls, offering additional context, particularly for younger patients. That's all for the video. We'll see you next time.